Let's start today's event. Hello and welcome, doctors, parents, caregivers, and fighters. I'm Dr. Prachita Shah, co-founder of PHI, and I live with Idiopathic PH. I live in Mumbai and I'm a clinical microbiologist by profession. I'm joined by my co-moderator, very beautiful Shalaka Parab, who is also the backbone of Pulmonary Hypertension India. And she lives with PH secondary to congenital heart defect. And she also stays in Mumbai. So let me first introduce PHI to you all. Pulmonary Hypertension India is a community platform and a support group that has been very lovingly and caringly curated to help Indian pulmonary hypertension patients with this debilitating condition. The uniqueness of this group is that it is managed by the patients themselves, and we pursue a common goal of empowering, educating, and enabling Indian fighters to make good decisions and the right choices in dealing with PH. We do this by making knowledge, access, and community our prime goals. We have been marking 5th May, the World PH Day, by creating awareness around PH and empowering patients with knowledge about disease management. We have been bringing educational material to Indian patients and caregivers all the month of May. So this is us, India's one strong patient voice in the fight against pulmonary hypertension. Today, we are going to discuss pulmonary hypertension in children and the genetic basis of it. So we have 3 eminent speakers with us for the same. We will try to get as many answers as possible for the worried patients and the caregivers. This session is going to be made available later for all the parents out there. So it's a very important session. Do not miss it. Make sure to listen and ask your queries at the end. The first session for today is about CHD and pulmonary hypertension, idiopathic PH, and management of PH in children. The panelists for this session are Dr. Neeraj Awasthy and Dr. Prashant Bobhate. I will first introduce them and give the floor to them. Dr. Neeraj Awasthy is the Director of Pediatric Cardiology at Fortis Escorts Heart Institute, New Delhi. After his master's in pediatrics from University of Delhi, he completed his fellowship in pediatric cardiology from NBE. He has 20 years of experience in the field with over 120 articles, 6 chapters, and 2 medical books under his name. His areas of interest are PH, intervention in various congenital and structural heart diseases, etc. He believes in the undying spirit of humans to overcome obstacles, which is portrayed so well in his latest book, In the Company of Me. And he has also made PH clinic functional in the Fortis Escorts hospital now. Coming to Dr. Prashant Bobhate, he is a consultant at Children's Heart Center at Kokilaben Dhirubhai Ambani Hospital. He runs a specialized PH clinic and is amongst the very few Indian cardiologists catering to PH patients. He has done his fellowship in PH from Stollery Children's Hospital, Edmonton, Canada. He has published 33 research papers and authored 7 chapters till date, with maximum being on PH. He is very active in managing PH patients with advanced medical and surgical methods. He is one of the pioneers in the pot shunt surgery, a life-saving procedure for many PH patients. A very warm welcome to you, doctors. The floor is yours. Shall we start the session?
Thank you. Thank you so much, Prachita, for the kind introduction. Yes, we can start.
Okay. So the first question I would like to ask is, what are the common symptoms of congenital heart disease in a newborn or infant? Like, what will you tell the parents how to detect them? So, Dr. Neeraj, would you like to take it?
Yeah, thank you, Prachita, for the wonderful introduction. And pulmonary artery hypertension is a much needed entity. I mean, it was something which was, I am thankful to this forum, which has given the opportunity to interact with so many of the fighters who are all around. As far as the pulmonary artery hypertension is concerned, most of the time, the nidus starts from the very, very beginning, when the child is very small, as you've asked. Most common symptoms to begin with would be those of an underlying substrate of the pulmonary artery hypertension. And most of the time, these are underlying congenital heart diseases when the child is small. Most of the symptoms are, one, the child would become very tired as he feeds. There will be excessive sweating. The child and to rest of the peers, he would become very tired, easily fatigable. These are some of the symptoms with which the child would actually present.
So tiredness and excessive sweating. So those two only we could hear.
Sorry, so I will just repeat, sorry for this interruption in between. Most of the time, the child would present with underlying substrate of a congenital heart disease, which is the commonest heart disease, the commonest cause of pulmonary arterial hypertension. So the underlying causes would be the child would become easily tired, fatigued. As compared to rest of the peers, he would become easily fatigued. He would not gain weight as compared to the rest of the feeding because of he would not be able to feed sufficiently because the lung, most of the time the abdominal is congested. As he feeds, the child would sweat a lot, and of course he will have breathing difficulty and repeated chest infection. All these point towards a quantum of increased flow to the lungs, or probably the insufficiency of the blood which is needed to whole of the body, pointing towards the early onset of a disease which later progresses to pulmonary artery hypertension.
Okay. So, the main question here is like, how do these ASDs and VSDs turn to pulmonary hypertension later in life? Why do these congenital heart diseases show PH later?
So, most of the time, when you have any of these symptoms, it is recommended that we pick up these things early. If we pick up these things early, it is likely that a suitable intervention can be done for this patient. Remember, in pulmonary artery hypertension in children, if we can pick shunt lesions earlier and we can treat those shunt lesions, they are less likely that they will progress to a severe PH situation or a Eisenmenger situation. So it is very important that these symptoms are picked early. If you have doubt, any of these doubts, if your child is having any of these doubts, it is very good idea to get in touch with your local pediatrician who will guide you to a pediatric cardiologist who is in turn going to do an evaluation most commonly by an echocardiogram. Echocardiogram is going to give in almost most of the cases, it's going to give you a complete diagnosis, and an appropriate action taken at an appropriate time is most likely to prevent progression to a congenital heart disease going on to a significant Eisenmengerization or a pulmonary artery hypertension. Maybe Dr. Prashant would like to add about other diseases. If Prashant, anything you want to add?
No, it is very well covered by, as Dr. Neeraj said, the problem lies in identification of the congenital heart disease. And there are various myths regarding congenital heart disease which are still there, prevalent in the country, not only among general people, but even among physicians and doctors. So the message here is to pick up the heart disease early and treat early. If we treat the heart disease early, then they wouldn't progress to pulmonary hypertension.
So, Dr. Bobhate, does it vary with the type of CHD? First of all, just please tell in brief how many types of CHDs are there? What are complex CHDs?
So CHD by itself is a very broad, CHD or congenital heart disease is a very broad spectrum of diseases. It ranges from a very simple one, like an atrial septal defect, which is a hole in the upper part of the heart, or a small connection in between the lung artery and the body artery, which we call as a PDA, or a hole in the lower part of the heart, which we call as a VSD, to a more and complex heart diseases, such as when one chamber of the heart is smaller than the other, which is called as a hypoplastic left or right heart syndrome, or certain isomerisms when, the parts of the body are not there where they're supposed to be. So if you have a liver on the right or liver on the left, instead of the right, it is on the left, or it is jumbled up. So these are that's a wide spectrum of congenital heart disease that we are looking at. The simple ones, as I said before, are the atrial septal defect, where there is a hole in the upper part of the heart, ventricular septal defect, and the PDA. So these lesions are the ones which there is increased flow to the lungs, And so these patients, initially, they are not blue. So these patients are not blue. And as Dr. Neeraj said, the most common symptoms in these patients are increased tiredness, increased fatigue, not able to gain weight, not able to feed properly, recurrent respiratory tract infections. The other diseases which are a little bit more complex, in which the great vessels or the of the heart of the body, such as the body artery and the lung artery, they get exchanged. So we call this transposition of great arteries or a TAPVC, or instead of two great arteries, only one great artery is coming, which we call as a truncus arteriosus. Or instead of two valves, there is only one valve, which is called as a AV canal defect. So these congenital heart diseases are a little bit more common. They are also associated with increase in the lung flow, but because the vessels are not coming from where they are supposed to be, these children can be a little bit more blue as compared to the simple, extremely simple congenital heart disease, which we explained. Now, these disease progresses to pulmonary hypertension earlier as compared to the more simpler ones. So if an ASD, VSD, and PDA, on an average, if most of the patients get treated by, say, 1.5 to 2 years of age, most of these patients would lead a near normal life. But if you go to the complex congenital heart diseases, where the patients are blue, as well as there is increase in the lung flow, these patients have to be treated maybe, in the first 4 weeks or 6 weeks of life, so that they can have a near normal future in the future. So the more complex the disease, the earlier pulmonary hypertension develops.
Okay.
And but we need to understand that most of these diseases are treatable. And most of these diseases would require a one-time surgery.
So that is the main thing here, that it is treatable. Dr. Neeraj, I would like to know what is the burden of CHD in India?
So congenital heart disease, which is among the commonest cause of pulmonary artery hypertension, as the spectrum was very beautifully discussed with by Dr. Prashant, is actually present in almost 3 to 8 per 1,000 live births. Now 3 to 8 means the incidence is almost the same all across the world. But what we say, it's a iceberg phenomenon. That means those heart diseases which we are actually looking at, they are just the tip of the iceberg. For what you see, there will be almost 8 times the heart diseases which will be subtle, which will be hidden, which may not actually have reached the evaluation to the appropriate doctor, or they are in such a small minor variants that they are not impacting day-to-day life. So definitely the heart diseases which we are concerned as pulmonary artery hypertension specialists are these group of diseases which are subtle, which are gradually the patient is well accustomed, which patients feel that he is good, but what is happening at lung pressures have started to increase, and that is why he feels slightly better over a period of time. It is these group of diseases which can get missed. So even some minor symptoms, if you are having, even if you're having a tachypnea, if your child is not gaining weight, if you feel the child is very weak as compared to rest of the peers, as has been repeatedly emphasized, it is very good idea that appropriate evaluation by a pediatric cardiologist is done to pick up these heart diseases early, because as Dr. Prashant said, most of them are single stage treatable. So incidence is almost 3 to 8 per 1,000 live births.
So according to you, many of these cases go undiagnosed.
Yeah, so many of them would be undiagnosed, because what we see in the routine, our OPD praxis, is just the tip of the iceberg, and many of them are not actually being screened.
So what is the scenario where we see that doctors will tell that these holes, they are small, or whatever the reason may be, they might close on their own? So in such scenarios, follow-ups are needed or not? How frequent should be done?
Yeah, it's a beautiful question, and I think it's very good idea that we always trust our physician. Yes, your physician is absolutely right. Many of these holes, when they are restricted, when the lung pressures are relatively preserved, these can be followed up and they get closed. But remember, there are many of them who would progress, who would increase to isomerization. What is this subset which will progress to isomerization? So as you have a hole which you feel, which has been pointed out as restrictive, and the child is having symptoms, it is a good idea to seek another opinion. It is always a good idea, because many of times we know that there is a spectrum of these diseases and evaluation have its own lacunae. So it's always a good idea that if you feel you have been pointed towards a hole which is restricted, or you feel it's always a good idea to take a second opinion and to look and find that maybe this is causing some pressure onto the lungs. So this is not just holes which are important. Remember, there's a spectrum of heart diseases which Dr. Krishna pointed out. So these holes may be associated with certain other diseases. So it is always a good idea, when in suspicion, always get evaluated by an appropriate pediatric cardiologist, because pediatric cardiologist is trained to pick up heart diseases since birth. And maybe this hole is small, but the associated disease which is there is significant. So whenever there are significant symptoms, it is always a good idea to get them appropriately evaluated.
Okay, sir. Dr. Bobhate, there was a case scenario where even after closing the CHD, the patient developed PH after a few years. So what do you suggest about follow-ups in patients who have done surgery when CHD was detected? So you're muted.
Yeah. So, again, it's a very good question. So, and a case scenario is not very uncommon. Now, it depends upon how this child has been evaluated when the heart disease was detected. So, there are many, many questions to this. First is, when was the heart disease detected? Second is, what was the condition of the child, especially what was the age of the child, what was the saturation of the child, what was the lung artery pressures at that point in time? Thirdly is, was the child evaluated in detail regarding what is the status of the pulmonary vasculature at that point in time? More often than not, and it's a learning process for us too. We need to understand that it is not a very simple thing. We need to take into, when we decide to operate a child of congenital heart disease who is, borderline. So what happens is, if the child is less than 6 months or less than a year of age, the decision is very easy. That at that point in time, most of the patients whom we close the hole, these patients are going to lead a near normal life. However, as the age goes on increasing, the chances of the pulmonary pressures coming down after doing the surgery go on decreasing. In fact, after a particular point in time, there was a very beautiful study which was published from the Netherlands, because they had a huge community community of patients, wherein they showed that if the child with the heart disease, the hole is closed later on in the life, there is an initial drop in the lung artery pressure, but it then comes up several years later as a very severe pulmonary hypertension. Maybe that may be 5 years, 10 years down the line. Now, what was the assessment of this child at that point in time when the heart disease was closed is extremely, extremely important. Probably the child has crossed the level where the heart disease, the closing of the heart disease would have actually benefited the child. So that assessment of the child while subjecting the child to closure of the heart disease or a heart hole is extremely, extremely, extremely important. And what happens is, if we have closed the hole and the child comes back maybe 5 years or 10 years down the line with severe pulmonary hypertension, that is even worse than having a hole and pulmonary hypertension. We all know that the patients with a hole in the heart, either in the upper part, that's the ASD, or the lower part, or a VSD or a PDA, they fare much better with pulmonary hypertension than somebody who doesn't have that hole. So if we have closed the hole later on in life and the child comes back 5 to 10 years later, these children have got much worse prognosis. So it's extremely important to assess the child at the time of closure, especially if the child is older. Say anything more than 1.5 to 2 years of age, if the child is older, it's extremely important that the child is assessed properly before closure of the hole.
Okay, so sir, I noticed 2 points. Please correct me if I'm wrong. So the surgery for CHD should be done by 6 months or at the most 1 year. And even after surgery, follow-ups should be done. But can you tell me the frequency of follow-ups?
So so it depends again on the scenario of the patient. So if the patient has been closed early in life, when we don't suspect that the patient would have pulmonary hypertension later on in life, we usually follow up these patients for up to 5 years. So after the surgery, 1 year, 3 months, 6 months, then annually for approximately 5 years. Then the simple heart diseases, we tend to discharge them from follow-up. If we are sure that when we had assessed the child was operable, and by 5 years the child does not have a complication, then we tend to usually ask these parents not to get them back for follow-up. However, this entire assessment has been, now if I have a child whom I have a doubt, or he was operated when the pulmonary vascular disease was probably set in, it was a borderline operable case. So in that borderline operable case, probably I would ask them to follow up with me every year for life.
Okay, thank you, sir. And sir, so Dr. Neeraj, if it is unclosed, if I'm not operating on the CHD now, if the doctor has not operated, so in that case, how many frequent follow-ups you would suggest?
So in case the PH is there, that means we have not operated, is an uncorrected congenital heart diseases. That means all the brunt of the shunt is being taken by the lungs. So whenever the brunt is taken by the lungs, the heart, normally the right heart is to function against the lungs, which is very, very soft. So any pressures which is more than 25 is high pressure. You can imagine this always works at a very, very low pressure, less than 25. The left heart is working at your blood pressures. Blood pressures are 120. So left side has to pump the blood to whole of the body. So it is working at a very, very high pressures. So once we have these uncorrected shunt lesions, that means this blood pressure, which is pumping to whole of the body, is getting transmitted to the lungs. So lungs are transmitted with very high pressure of blood pressures, and they gradually become stiffer and stiffer. If we understand this pathophysiology, then we understand what will be the frequency of follow. As Dr. Prashant said, the underlying substrate is very, very important. As the lungs become stiffer and stiffer, the heart on the right side has to work more. And the heart, which is supposed to work at 25, now working at 120, is likely to fail. So what decides the frequency of follow-up is, one, what is the underlying symptoms of the patient, how significant symptomatic the patient is, which we offer all of us in PH clinic. We are doing a 6-minute walk test. We try to see how the patient is walking. Many of us are doing a CPET, cardiopulmonary exercise testing, to see how you compensate your status. And then we look at the evaluation of the heart in the form of echocardiography to see how the right heart is functioning. And at times we go to blood parameters to see whether the heart is at a stretch, looking at a BNP levels, or there are secondary complications in the form of polycythemia, in the form of the blood getting thicker, such as polycythemia, in the form of uric acid becoming high. So all these are the secondary implication of any congenital heart disease with Eisenmengerization. And the frequency is essentially decided by all these parameters. In usual course, with very compensated heart failure, with appropriate 6-minute walk test, and the patient responding beautifully, the frequency is generally once a year. But having said so, in case we have to alter the medicine, we see the response to therapy, we call them at around 3 months or 6 months. So these are the parameters which decide as to what is the underlying substrate. At this point, I would like to point at one important thing. Remember, all pulmonary artery hypertension is not congenital heart diseases. There is whole gamut of problems which can lead to pulmonary artery hypertension. So the most important follow-ups would be the few initial follow-ups with your physician who is dealing with pulmonary artery hypertension. He is trying to evaluate some treatable cause of pulmonary artery hypertension before labeling it as idiopathic pulmonary artery hypertension. So those follow-up may be slightly more depending on the evaluation, whether he's trying to look at underlying autoimmune phenomena, or he is trying to look at underlying etiology, such as aberranthy or abdominal problems which can lead to lung pressures being high, trying to get a CT evaluation done, trying to do an angiography to ascertain whether we need to I think there is some interruption. Close as compared to follow-ups, which would be henceforth. Once you have optimized, the follow-up generally ranges from 6 months to 1 year.
Okay. Thank you, sir. Dr. Bobhate, in your clinical experience of treating PH in children, especially idiopathic, what workup should be done for labeling idiopathic?
So there is a whole list of workup which we do for before labeling a child as idiopathic pulmonary hypertension. Of course, we do a CT pulmonary angiogram to look at if there is any shunt lesion which we have missed, which may be distal to than what can be seen on an echocardiogram, or if there are blockages in some of the lung arteries, or if there are additional lung connections in between the body artery or the lung arteries, which may be big enough to cause pulmonary hypertension. At the same time, what we have made a protocol is to scan the abdomen also at the same point in time when they're doing the CT chest with an angiogram, just to cover the abdomen also, because as rightly pointed out by Dr. Neeraj Awasthy, there are a whole gamut of problems, especially in children. If there is an abnormal connection in between the gut vein and the body vein, which we call as a Abernethy malformation. Now, this is a relatively more common cause of pulmonary hypertension in pediatrics as compared to adult patients. So we should look at them. We should also look at the status of the liver, if there is, if the liver is functioning well. And it can be done both as on ultrasound as well as a CT. But since we are doing a CT, we tend to cover that in CT only, so that the child gets through that in the same thing. Of course, before doing a CT, an echocardiogram, a thorough echocardiogram by a pediatric cardiologist has to be done to rule out any other cause of pulmonary hypertension, especially certain congenital heart diseases which may be missed. After doing the CT and the echocardiogram, we also advise an ultrasound abdomen. Then we look at various blood tests to look at if there is any, as Dr. Neeraj pointed out, is there is any autoimmune cause for pulmonary hypertension, although it's a little rare in children with pulmonary hypertension, but nevertheless, it's worthwhile to do it because you never know which patient has what problem. And last but not the least is a genetic testing, which needs to be done to confirm or refute that the child has a genetic cause of pulmonary hypertension. Now, we always give this choice to all our patients, whether it is adult as well as pediatric, so that they know if there is any genetic cause of pulmonary hypertension. We also would like to do a right heart cath in most of our patients to look at what exactly the lung pressures are. And that is not only to look at what lung pressures are. There are various pressures which we look at, various parameters which we look at, including what we look at is cardiac output. And the more important while doing a right heart cath is what we call as doing a vasodilator testing. So if we give the child inhaled nitric oxide, which is specialized gas, to see if the lung pressures decrease after giving that inhaled nitric oxide. And if that happens, the child, the prognosis as well as the management is much better in the children who respond well to nitric oxide. So these are some of the investigations which we do in a patient who is suspected to have pulmonary hypertension. So we do some tests to find out the cause of pulmonary hypertension, namely the echocardiogram, the CT, the ultrasound abdomen, and certain blood tests. Then we do certain tests which we would like to understand how do we treat the pulmonary hypertension. So for that, we require a right heart cath. If the child is more than 6 years, we do a 6-minute walk test. And we also do a test, which is blood test, which is called as NT-proBNP, which will tell us what is the status of the heart. And then we plan the management.
So in children, sir, does RHC need any type of anesthesia or not needed?
The right heart cath in children would require an anesthesia. It may not be general anesthesia. We most of the times we try to do it under sedation and local anesthesia, but sometimes yes, the child may require general anesthesia, and it is prudent that you do it in a unit which is having anesthetist who is trained to do that, because more than the cardiologist, the work of the anesthetist is extremely important when doing a right heart cath, especially in children, because most of the unwanted side effects or the unwanted dangers happen during or giving the anesthesia, or just after giving the anesthesia, or just when they are getting the child off anesthesia. So an anesthetist who is an expert in managing such kind of patients is extremely essential. So more often than not, while doing a right heart cath, more than the cardiologist, the anesthetist is extremely important uh, uh, to have a procedure which can sail through.
Okay, okay. Thank you. Dr. Neeraj, I would like to ask about correlation of Down syndrome and pulmonary hypertension. Any cases if you have encountered?
So Down syndrome is among the commonest syndromic association which any of us see in our routine practice. With respect to pulmonary artery hypertension, there are important secondary causes which are present in Down syndrome, which leads to pulmonary artery hypertension. Of course, one of the important causes which we have been discussing is associated congenital heart disease. The most common congenital heart disease in these subset of patients is AV canal defect. That means atrioventricular septal defect. What is it? There is a hole in the upper part of the heart, which is between the two atrias. There is a big hole in the lower part of the heart, which is between the two ventricles where the main pressures are. And there is a one common AV valve. Because of this, there is a transmission of systemic pressures of around 120 the blood pressures onto the lungs, and these patients go into isomangalizations. So go into significant pH. So it is important that this is one of the treatable causes of pulmonary artery hypertension. So any case of Down syndrome, if it is there, he should be subjected to echocardiography early to pick up this congenital heart disease so that it can be treated. And at least if the child is treated of a congenital heart disease, one of the important cause of pulmonary artery hypertension is omitted. Yes, there are few other causes of pulmonary artery hypertension which would be less common than this in case of Down syndrome. Most common being these children are generally have got good weight. They tend to have thyroid derangements. So it is good idea that a regular follow-up with the physician with thyroid checking is done, because many of these lead to secondary causes of pulmonary hypertension in the form of upper airway obstructions, because they tend to have tongue falls, or because of tongue fall, the upper airway gets obstructed, or even minor short neck and tongue fall leads to even a minor infection in URI at times leads to increased pressures in their lung. So it is good idea. We train whenever incidentally we are also associated with Down syndrome association. So all our Down syndrome patients, we encourage that they do not sit straight. You realize that most of the Down syndrome patients do not sleep straight because of the tongue fall, they are very prone to have high upper airway obstruction and secondary apneas as a cause of secondary cause of pulmonary hypertension. Always advise them to sleep on one side to prevent this tongue fall. One second, they have a tendency for weight gain, not just because of thyroid, because of sedentary habitus. Most of the Down syndrome, you'll find that they are slightly obese. Encourage them to participate in activities, encourage them to have an appropriate weight. In fact, they can be encouraged to see the weight for themselves. Look, today your weight is 24 kgs. Your weight has become 26 kgs. So you can always talk to them. So all these things encourage them to control their weight. And weight is another secondary cause which leads to getting up, leading to lungs getting compromised, and secondarily leading to high pulmonary artery pressure, pulmonary hypertension. Last but not the least, which I've already emphasized, secondary causes should always be evaluated in the form of hypothyroidism, because this is one of the important treatable causes which is associated in Down syndrome in pulmonary artery hypertension.
Thank you, sir, for those important points. So next question, Dr. Bobhate, sir, can you please answer what are the challenges faced by children with PH and their family?
The challenges faced are multifold, and the challenges faced are would be quite different from each patient. However, broadly, the challenges would be, one is taking care of the medications, taking care of the patient himself or herself, because they're not able to take care of themselves. So this is a very, very important challenge. The medications which we use in pulmonary hypertension are quite costly. Most of these children tend to fall ill quite frequently. So one of the parents or the caregivers needs to take care of this child. Second is, when these children go to school, they sometimes get a complex because they are not able to run or not able to play as much as their peers. So there would also be a psychological impact of this disease on the patient uh, from the school point of view. Although most of these patients are quite intelligent, because they are reading quite a lot and they are doing activities which are more or less sedentary, so they're quite intelligent. PH patients, especially the pediatric PH patients, are quite intelligent. But I think the aspects are, and they are not able to take part in competitive sports. So that is another drawback which this patients face. So the problems, I mean, the problems faced are medical. Because of the medical, they have to keep on popping up pills every now and then. Sometimes they may have to pop up pills during their lunch break or during their snack breaks, which kind of by itself may be distressing for these patients. uh, Addition of the medication adds to a financial burden to the family and the caregiver, because these medications are nevertheless quite costly, as we all know. Then the problems, as I mentioned previously, are psychological on the child himself or herself, because not being able to take part in the routine activities which a normal child should be able to take part at that age group. Playing is a normal phenomenon, but these children are tend to not run around too much. They tend to use sedentary sports or sedentary games to, entertain themselves. So these are some of the problems which are faced. And then this disease is progressive. It is, if it, especially if it is idiopathic or a heritable pulmonary hypertension, this disease is progressive, and uh, the patients kind of get distressed, and the disease kind of progresses as the patient's age increases. So with the increase in the disease, again, these problems become multifold. When these children become adolescents, there is another problem, because in adolescence, because of the lot of hormonal changes, especially if the child is a girl child, the disease also tends to progress during the adolescence age group. So these are some of the problems which are faced by the PH patients, especially who are pediatric, when we're talking of pediatric PH patients.
Thank you, sir. So, Dr. Neeraj, would you like to add anything from your 20 years of experience about challenges the PH patients and their families face?
Prashant has beautifully highlighted the problems, but yes, I agree with him totally. It is not that the problems are the medical, the problems are financial, the problems are psychosocial. Remember, what I believe is the psychosocial problem is something which we as a group have to really address. We can actually talk to them. It is very important that a positivity stays in the family. It is true for any disease, and it is very much true for pulmonary artery hypertension. So most of the time, it is not just the disease; it is the secondary mental trauma, depression, and then many times Googling the things, and Google giving us all sorts of abnormal information about pulmonary artery hypertension. PH is a disease in which, if appropriately treated, the patient is going to have a good lifespan. He is going to have, yes, he might have hospitalization in between, but remember, his mental status is much better than many of the patients with other congenital heart diseases. Second, PH is a condition where if the patient continues to be on a regular medicine, he is likely to delay the progression of medicine, the progression of the disease. It is not that the disease would always be supervene. There are many myths in pulmonary artery hypertension. Third, pulmonary artery hypertension is a condition which may have a treatable cause. And it is this treatable cause which if picked appropriately, one can actually treat a pulmonary artery hypertension completely. So yes, these pulmonary artery hypertension evaluation may have its own financial implications and a few tests which may be needed. But remember, if your doctor picks it up, underlying cause, you may not actually need all those medicines for life. Fourth, going in for surgery is not always the final solution. At times, no surgery is better than operating a patient. If you don't operate a VSD, a large VSD with Eisenmenger, he's going to have a normal, yes, he might have a few hospitalizations. Intermittently, there might be problems, but on the whole, he is going to have a reasonably good quality of life. But if you operate that VSD Eisenmenger, you are actually going to deteriorate the quality of life. So at times, the surgeon may not be needed for treating a pulmonary artery hypertension. Many a times, a good support system is all what is needed. Remember, whenever we are stressed, we are increasing our heart rate, we are increasing our diastolic filling, we are compromising the already compromised heart and already compromised flow to the lungs. So if you can do anything good for yourself and your patient is, then stay happy.
So then, sir, would you recommend palliative care for these patients?
So palliative care is I have some apprehension about this word palliative care. So remember, palliative care, there is no for pulmonary artery hypertension. Pulmonary artery hypertension is the supportive care. Palliative care is for those patients who are moribund, who are in bed, who are actually trying, are going to have quality of life. All they need to do is they need to have a supportive care, a support system, a support family, a support social structure, which tells them that yes, you are going to do good. Your 6-minute walk test is going to get better. Even if it is not getting better, your escalation of medicine is going to give some positivity in life. The problem is not with the patient. The problem is with the family. The patient may be happy, the family is depressed because they keep on Googling the whole sorts of things about pulmonary artery hypertension. So it is not just a disease of the individual, it is a disease of the family. So if the message which has to go, one message to all the families is, if you can do anything good for yourself and anything good for your patient is, stay positive. Because if you are staying positive, you are going to decrease illness in yourself. You are going to receive whole scourge of hypertension, hyperlipidemia, eating deficits, all those hormonal problems to yourself, and at least you can take care of the person who is having pulmonary artery hypertension. One, and secondary, you are going to give a secondary vibes to that pulmonary artery hypertension patient who is already having the disease. And if he gets, he is going to get worsened. What are we doing nowadays in newer therapies in pulmonary hypertension? We are trying to get the sympathectomy done, trying to decrease the sympathetic tone, trying to decrease the tone in the artery so that we relax. What are we doing with stress? We are again increasing the tone. So we are counterproductive to the medicine which we are giving. So if you want to be productive to the medicine you give, stay positive, stay happy.
And don't Google.
Consult your cardiologist.
Yes, sir, definitely. Okay. Dr. Prashant, we would like to come to the medical treatment of PH in children. How is it different from adults?
So it's not too different if you ask me. And here we are talking of idiopathic pulmonary hypertension or maybe even heritable pulmonary hypertension. So the medical management of PH in pediatric is not too different from what an adult is. However, there are certain medications which we tend to use more in pediatrics as compared to adults. Something like a bosentan, we tend to use more in pediatric patients, especially if the child is less than 2 years of age. So if the child is less than 2 years of age, the endothelin receptor antagonist of choice in these patients is bosentan. In an older child, the drugs by themselves would remain the same. So you always have an upfront combination therapy, whether it's an adult patient or a pediatric patient, with two medications like a phosphodiesterase 5 inhibitor, which is a sildenafil or a tadalafil group, And the second one is the endothelin receptor antagonist, which is the bosentan, ambrisentan, and the macitentan. And then however, the problem in pediatrics is the dosage of these medications is not well standardized. We have a rough guideline as to how and how much medication which we are going to use, and the dose may have to increase depending upon the patient's age. So this the PH physician or the treating physician needs to take care that with the increasing age of the patient, with the increasing weight of the patient, the dose may have to increase as compared to an adult when the dose is kind of standardized for a particular value. Second is the risk stratification is extremely important. Although there is no standardized risk stratification in pediatrics, we tend to use the adult. Tend to or what do you say? We tend to use the adult risk stratification systems and apply the same in pediatric by doing slight modifications in those systems, which helps us in kind of regularly monitoring these patients, to kind of helps us in identifying the disease progression. It helps us to escalate the medications much earlier as compared to when we would have done it if the patient already has progressed to a high risk category. So try to keep the patients in the low risk category. Although I understand there are no standardized formula for this, but we have kind of using the adult ones and modifying it for pediatrics. Second is there are certain therapies in pediatric pulmonary hypertension which have found to be more useful as compared to adults, especially something like a pot shunt. When you create a connection in between the lung artery and the body artery, this surgery or this intervention has found to be much more useful when you're doing it in a pediatric patient, less than 14 years, less than 15 years. The efficacy of this procedure is much higher as compared to what can be seen in adult. Now we have started to extrapolate the same pediatric data into the adult patients, and we are seeing mixed results. Some of the patients do extremely well, some of the patients don't do well. So we are still learning. We're still learning in our learning process as to identify which patient would do well, and we have kind of certain guidelines which we have made for ourselves as to which patients would probably benefit from doing this procedure. But definitely in pediatric patients, it is much more useful as compared to adults as of now. Then there are certain issues in pediatric or certain causes of pulmonary hypertension in pediatrics, such as the Abernethy malformation, or when there is an abnormal connection in the abdominal vessels or the vessels in the tummy. And when you close this malformations, the pH is treatable. So the pulmonary hypertension may actually reverse. So these are some of the differences which we have in pediatric pulmonary hypertension as compared to adults. But more or less, it is just a reflection of what adult practices. And of course, the lung transplant scenario in pediatric is slightly different as compared to an adult, because as such also the lung transplant, I would not like to, I mean, the lung transplant even in adult patients, it has to be done at an appropriate time. It should not be either too early or too late. But in pediatrics, even the problem of transplant is to find an appropriate donor to get that size of lung, which can be accommodated for that particular patient. So the transplant scenario in pediatric patients is a little bit more naive as compared to what has been adult. Transplant programs are usually well settled or well established, but the pediatric transplant programs are still, trying to get to that level. So these are some of the differences of practice in adult as well as pediatric, adult as compared to pediatric pulmonary hypertension.
Okay. And sir, regarding the advanced medications like selexipag or prostacyclin analogs, which are used in adults, so are they is there any documented evidence to use in pediatrics, or they are not used?
So they are definitely used in pediatric pulmonary hypertension. As of documentation, see what happens in pediatric pulmonary or in pulmonary hypertension, especially in children. Whenever we or if you have to do a study, if you get the children in picture, then the approval of the study doesn't come, right? So most of the studies or most of the medications in pediatrics, it is off-label use. Most of the patients, most of the medications, even in pulmonary hypertension, there is off-label. What do you mean by off-label? Means a study has not been conducted to demonstrate the efficacy of that medication in that age group, but doesn't mean that that medicine cannot be used. Okay, if that medicine can be used judiciously. Like, for example, in our PH clinic, I have around 14 pediatric patients, that is less than 17 years of age, who are taking Selexipag. Even the iloprost which we were using, our youngest patient was 3.5 years of age. So these medicines can definitely be used in pediatric. Even the subcutaneous treprostinil, this can be definitely used in pediatric patient. There was a study which was published, and I think even when I was in Canada, we had a case series. We had published a case series of 12 patients who were on subcutaneous treprostinil. So yes, it can be used in pediatric patients, but you should consult a physician who is tuned to use it in pediatric patients. So who is probably going to be a pediatric cardiologist.
So sir, in India means advanced medicines are being used
Yes.
for
Yes.
pediatric patients also.
Yes.
So Dr. Neeraj, what has been your experience with the advanced medications? And if they run out of options, what do you suggest to the patients?
So any pediatric pulmonary artery hypertension clinic, as a matter of fact, pulmonary artery hypertension clinic has got its own escalation protocol metrics. There is definitely a line of metrics, line of armamentarium which we are using for treating pulmonary artery hypertension. And basically, we all of us have three pathways are acting. We try to gradually escalate the medicines to first line, second line, and third line drugs. And at times, many of these drugs which are not available in this country, as Prashant has also pointed out, such as Idioprost, we actually are procuring it through our channels and giving it to the benefit to our patients. So most of these pulmonary artery hypertension clinic are trying to have a combination of medical management, to have a functional class assessment of these patients, and subsequently tailor those medicines with respect to functional class. What additional we are doing is probably what I have been discussing is PH is not just a disease of the individual, PH is a disease of the family. So it is always good idea that a good family counseling is done whenever starting the patients on medicine, and these are reinforced appropriately. Personally, we and of course many of us pulmonary artery hypertension clinics have incorporated many of these yoga exercises into pulmonary artery hypertension, and I strongly believe that many of them would be a good substitute with our medicines to actually help them out with pulmonary artery hypertension. The rest of the things I think Prashant has beautifully highlighted.
Okay, thank you, sir. And let's close. I would like to close this session now, and we will wait for Q&A session after the genetic session is done. Is it okay with you, sir? So,
Yeah, should be fine.
Sure.
Okay, after maybe around 20 minutes, we'll go for Q&A for both the sessions. Thank you, sir. I would like to now introduce Dr. Ram Krishna. Good evening, sir.
Hi, good evening.
Dr. Ram Krishna is a consultant pediatric and fetal cardiologist at Tiny Hearts Fetal and Pediatric Cardiac Clinic, RK Hospital, Tanjavur. He is a visiting consultant in pediatric cardiology at Kaveri Hospital. He is a gold medalist in pediatrics masters. He has also done fellowship in pediatric cardiology from Children's Hospital at Westmead, Australia. He is recipient of Dr. Anita Saxena Award for Innovation in Pediatric Cardiac Sciences. Along with this, he is interested in inherited cardiovascular diseases and channelopathies. So let's use this opportunity to make the best for tiny humans and their worried parents. So thank you and welcome, Dr. Maniram. Shall we start with questions?
Sure. Hi, thank you for the kind introduction. I think you need to make me a co-host because I'm unable to share my slides.
Yes, sir, 1 minute. So now you can share mostly.
So can you see my screen?
Sir. Yes, sir. It's gone.
No, can you see my screen?
No, no. It was visible before. Now it's not visible.
Can you see now?
Yes, sir. It's visible.
Okay. So, good evening. At the outset, I'd like to thank Pulmonary Hypertension India for the amazing work which they do. They've been really helpful to quite a few of my patients as well. And they've even actually gone to the extent of obtaining free medications, supporting a lot of my patients emotionally, especially the slightly older patients who have definitely benefited from talking to some of you in PHI. And thank you for giving me this opportunity to join Dr. Prashant Bobhate and Dr. Neeraj in this forum. So I'm going to talk something which is a bit different from what Dr. Neeraj and Dr. Prashant discussed, which is about the clinical aspects of pulmonary hypertension. So I'm going to switch over to the genetic aspect, and it's going to be very brief, just around 5 to 10 minutes after which I'm happy to discuss the questions which you have. So, genetics is a big thing in today's world, especially in medicine, where we are moving towards an era where the treatment is tailored to the individual patient. So it's not just in medicine, in every aspect of our lives, genetics seems to be playing a more important part. So I'm going to illustrate just two key concepts of genetics and pulmonary hypertension. And I'm going to illustrate it with real life scenarios. These are patients with whom you might be able to relate to, because some of you might have gone through this very experience. So this girl, unfortunately, I did not look after this girl. She was diagnosed to have pulmonary hypertension at 6 years of age and was treated with dual pulmonary vasodilators. But unfortunately, she did not respond to the treatment and she died within a year of diagnosis. Now, her father, her paternal aunt, as well as paternal grandmother, all had multiple skin lesions which looked like this. This is not a true picture. This I downloaded from the internet. But they had skin lesions which look like this. And these are telangiectasias. So when you have pulmonary hypertension and these telangiectasias, you tend to think of a condition called hereditary hemorrhagic telangiectasia. So the doctor who managed this patient suspected that this would be the case in this girl, and he did genetic testing. And this showed that this child indeed did have hereditary hemorrhagic telangiectasia. Now, they were told that this was a genetic disease and that the child must have received it from her father. But they did not explain the implications of this diagnosis in detail to the family. This child died, and 10 days after the child's death, the uncle met me in my clinic. So this was in 2021, and this was during the height of the second wave of COVID. So the family lived in an adjacent district and they were not able to travel to meet me. But the uncle came to meet me. Obviously, he was very upset because his niece had died recently. But there was one question which was, sort of a burning question in his head. And the question was, my sister has an elder son. And if this is genetic, what is the implication for him? So then we sat with him and discussed the entire family history. And we were able to find out that multiple family members had these typical skin lesions, which are associated with the gene which was diagnosed in the girl. So the question was, what is the implication for this for her elder brother, who was apparently asymptomatic and 9 years old? So he wanted me to, when I told him that there was a 50% chance that the other boy had that gene, he felt that that was not enough to convince his sister as well as his brother-in-law, who were obviously mentally very upset and who were shocked that they had lost a child, to come and meet me and bring their son. So what I suggested was that we will first do a genetic testing for the boy. So this is what we call cascade testing. where we look, we look for the same gene fault which was identified in the relative. So I told him, if the genetics is negative, then they can be reassured that the boy is unlikely to have the disease and they can continue a normal life. And whenever they feel composed enough, they can come and meet me. So we organized for genetic testing to be done from their hometown itself. But unfortunately, the genetic testing revealed that this boy carried the same gene fault which his sister had, and which meant that he was probably also at risk for pulmonary hypertension. So now the family history changed slightly, and we realized that the boy also has the genetic form. So we were left with no option but to ask them to come immediately for evaluation of the boy. Now, when he came to me, this apparently asymptomatic boy turned out was not really asymptomatic at all. He was becoming breathless if he ran up more than one flight of stairs. He was not able to compete in sports as well as his peer age group children were able to do. But he had got used to the notion that this was his capacity, and he had learned to restrict his lifestyle to within his limitations. So even though on the outside, this was a really well-built 9-year-old boy who was, some 38 kilograms, and apparently, going to school, doing all the activities expected of him, in reality, he was actually having some limitation of activities. And when I did his echocardiogram, it was clearly apparent that he had pulmonary hypertension. His right ventricle was very thickened, and even though it seemed to be functioning well, the right heart pressures were very high. Dr. Neeraj mentioned that this should be around 25, which is a normal. His was 75, which is what you expect in the other side of the heart. Thankfully, his right heart function was normal, and that was why he was reasonably asymptomatic. But now his pedigree, which initially had started with a question mark, later showed to be just a genetics positive, in reality was both symptom positive as well as genetic positive, and he needed treatment for the same. So we started him on dual pulmonary vasodilator therapy. At baseline, he had marginal heart failure based on blood investigations. But now it's been nearly 2 years since I first met him. And in his last review, he was reasonably okay. He was able to walk 450 meters on a 6-minute walk test with no significant fatigue, which I think both Dr. Prashant and Neeraj would be happy to accept for any of their pulmonary hypertension patients. So genetics and pulmonary hypertension. So it is now evident that more than half of what was labeled as idiopathic pulmonary hypertension or pulmonary hypertension without a known cause is actually due to a genetic problem. And the genes which are responsible for this have been most of the genes have been clearly identified. And these are the subset of genes. We divide them into 3 major groups, which are associated with pulmonary hypertension. Now, but the use of genetics is not just to identify family members at risk. There are also other important uses of genetic testing in pulmonary hypertension. One of the uses is prognostication. So if supposing a patient has a variant in BMPR2, then they are more likely to have a more severe disease, and they're likely to receive one of the advanced drugs which Dr. Prashant mentioned, the drugs which are more expensive. So you don't have to waste time looking at tests to see if cheaper medications would work, because they are very unlikely to work in this subset. So that is going to save you time as well as money in doing some tests to see if there are other treatment options. And similarly, there are some genes where they can present at a much younger age. So if that gene is identified in a family member, then you need to keep a much closer eye on them than you would otherwise. But is that the only implication? Definitely not. We are moving to an era of personalized medicine where the treatment is tailored to an individual's genetic background as well as additional factors. And I like to highlight it with one case example. So this was a 13-year-old boy who presented to me in late 2020 with recurrent episodes of syncope. All the episodes were during exertion, but otherwise his effort levels were normal. He did not have significant heart failure symptoms. It was just that sometimes when he exerts himself, he had a fall, a faint. But clinically, he had definite pulmonary hypertension. So we started on medications for that. And then we did genetic testing, which identified a change in a gene called KCNK3, which has been recently identified to be associated with pulmonary hypertension. So this gene was first described in pulmonary hypertension only in 2013. Before that, we didn't know that this gene could cause pulmonary hypertension. But even by 2017, people were able to understand how this gene was causing pulmonary hypertension. And they have actually started looking at ways at which this gene can be modified so that pulmonary hypertension does not occur in somebody who has a fault in this gene. And I'm actually happy to tell you that there are actually preclinical work trials going on a medicine which could specifically work for people who have pulmonary hypertension due to this gene. And the very patient whom I described, his cell line is being used in the preclinical stages to see if a drug can be used against this specific problem. So the implication of genetic testing, again, in the current era, the main implication is cascade testing, where you can potentially identify other family members who could be at risk for the disease, but who have not yet been identified. And you can start treating them at a very early stage so that you could postpone complications due to the disease. It is also useful for prognostication because certain gene faults are considered bad, and you might have to give a bad news to the patient and prepare them mentally for a long drawn course. But as we advance in our understanding of genetic disease, personalized medicine or a therapy which is specific to the gene fault identified in the particular patient will very likely be a reality in the lifetime of patients who are diagnosed with pulmonary hypertension today. So it is not in the very far future, or it's not going to be something which is only going to help the next generation. This is something which could likely happen in the very near future. So just looking at our cohort, in the last 2.5 years, so we've had 9 patients with idiopathic pulmonary hypertension, of which only 7 had agreed for genetic testing. And we have identified 2 patients with BMPR2, 1 with KCNK3, 1 with ACVRL1, which is hereditary hemorrhagic telangiectasia, 1 patient who actually had central hypoventilation resulting in pulmonary hypertension, and another child with pulmonary hypertension diagnosed during a lower respiratory infection who actually had a skeletal dysplasia, which sort of made him more prone for lung infections and pulmonary hypertension. And only one of those patients which we had tested was actually negative in this cohort. So that's the end of my presentation. I should again thank Pulmonary Hypertension India for giving me this opportunity, and I'm happy to answer the questions which had actually come up and which Shalaka had shared with me. Let me just end screen share. Yeah.
Thank you very much, sir, for the wonderful presentation. I would like to start with the questions. So first, you mentioned about cascade testing. So can you please mention about till what family tree should we go and test? Like only parents, should we involve grandparents, uncles, aunts, cousins? Like to what extent it should be done?
So what you do is you first test the parents. If any of the parents have it, so supposing the father and the mother, they both don't carry the gene, that means that this is a new onset change for the child. Then you don't have to do cascade testing for any of the family members. You need not test the siblings, and you need not test relatives of the parents as well. Suppose if one of the parents carry that change, then you need to test all siblings. and if possible, you need to test the grandparents. So supposing the father has it, you need to test the paternal grandparents.
Okay.
If any of the paternal grandparents carry it, then you need to test the father's siblings as well as other family members in the side of that grandparent.
Okay.
If paternal grandparents are not available, say they've died, or then you need to check all the siblings of the father.
Okay.
So the first line of testing is for the parents, and then if they are negative, so whenever you do cascade testing, if you come across a negative family member, you can stop testing for that member's side of the family.
Okay, sir, got it. And sir, regarding the mutations, you told that there are three major families of mutations in hereditary PH. So, how many of them implicate like severity of PH, and which of them are common in Indian children?
So I think so the three major families, of which the genotype-phenotype relationship has not yet been clearly established. But what we do know is that BMPR2, which is the biggest subset, is the one which has the more severe disease. So world over, I'll say almost half of genetic PH patients have mutations in BMPR2. And even though we don't have published data to the best of my knowledge, from whatever work I've done in Amrita with Dr. Shine, it seems that BMPR2 is the commonest in India as well. And I'm happy for Dr. Prashant also to share his experience to see what it was in.
Hi. So, so in our unit, we have done genetic testing for 37 patients till now, and out of which around 25 are positive. But to my surprise, I got BMPR2 positive in only 2 patients. The remaining are all other genes such as SOX17. Then 2 of them turned out to be hereditary hemorrhagic telangiectasia. One patient has KCNK3, which was highlighted by Dr. Manira. And a few of them are Notch2, one of them is SMART9. So various gametes, but BMPR2 was positive only in 2 patients.
So we are still yet to know like what is more common in Indian children. It will take time, I suppose.
Yeah.
Okay. Back to Dr. Manira.
Prachita, can I ask a question here?
Yes, please.
Yeah, to both the doctors. Sickle cell disease is very prevalent. It's quite prevalent in India. So is that one of the considerations for genetic PH in a way?
You can't really call it as genetic PH because sickle cell anemia, I mean, although sickle cell anemia is genetic, but it doesn't fall into the preview of genetic PH.
Right.
So,
but we do have a large
yes,
of
the central
patients
part
among
of
sickle
India.
cell disease.
Unfortunately, none of us practices in that area, but sickle cell anemia is one of the very most common causes of pulmonary hypertension. Actually, there was one study which was done by one of the fellows when they were doing MD pediatrics in Varda, and they shared their results with me, which they had done. They had done the PH echo for all patients of sickle cell anemia, and almost I think around 13 or 14% of their patients had pulmonary hypertension. So it was quite interesting to know. I don't know if they have published that study, but they definitely shared their results with me a year back.
Okay, thank you, doctor.
So we interestingly had a study on sickle cell anemia, and this was in a referral population in a tertiary care center in a government hospital, and where they actually did the echo evaluation for pulmonary artery hypertension, same as what Dr. Prashant has beautifully highlighted. Interestingly, sickle cell anemia presents with all the other problems, but pulmonary artery hypertension somehow in our groups of patients was not that very common as compared to, I mean, maybe what you have found in your substrate. Maybe the prevalence zone of sickle cell anemia is different, although we have not done any genetic testing for sickle cell anemia. So more of a prevalence study and doing echocardiography for other diseases, including pulmonary artery hypertension. It was from a tertiary care center in a government hospital in Safdarjung Hospital. Yeah.
Thank you so much, Dr. Neeraj and Dr. Prashant. Coming back to Dr. Maniram, I would like to ask about, are there any variations, means in the PH progression? Do the mutations affect the PH progression?
So I think, BMPR2 group of genes, they tend to progress much faster compared to other genes. So, if you identify that at presentation, even if your patient has mild disease, you need to, treat them more aggressively. That is all we are able to make out based on the available information. But, things might change as we understand the genetics of this disease more.
Okay. Sir, and as we know, this disease already carries the financial burden. The most important question we have here is, what is the test cost, means genetic test costing?
So the thing is, the cost is a major issue, I understand, but you need to go with the genome-wide study, exome-wide study for identifying the genes in PH. I would not recommend going for any specific group alone analysis. You're able to do it at a reasonable, but the cost of genetic testing in India is probably the lowest in the world. So I would say it probably costs less than 20,000 rupees to do genetic testing, and we have ways of doing it. Like if the family agreed, I've never, I come from a sort of tier 3 city. I work in a tier 3 city, and the vast majority of my patients will find 20,000 to be a huge amount for them. Because they need help with getting dual pulmonary vasodilators regularly for the child. So this is a huge amount of money for them. But we have ways of getting it done. We have research labs which are willing to do the testing for us. And we are also able to help by negotiating good rates for testing with the commercially available companies. So I think you should be able to do it for less than 20,000. And if the family is from a really financially backward, lower socioeconomic status, we should be able to help them out for much less than that as well.
Okay. Sir, and can you please tell us about your research in this area?
So, like as I said, I showed you some background data on what we've done, and it's a very small cohort, unlike Dr. Prashant, because I've only been here for the last 2.5 years. But it's a reasonably well worked up cohort, and surprisingly, the number of positive genetics is very high. Usually, the number quoted is around 30% only if you look at the literature. But even Dr. Prashant's data suggested that close to 70% of the patients had a positive genotype. And even in my limited experience, 7 of 8 patients had a positive genotype. As such, we are not able to offer any specific treatment based on the genetic positivity at the moment. But as I mentioned, this KCNK3 appears to be the most promising of all the genes in which a potential curative medicine could be available in the near future. So there is a preclinical trial going on, and as my patient with the variant, they have actually signed on to that preclinical trial. So they have made a cell line in the lab. They have made a cell line based on the genetic change detected in him, and they are looking at testing the drug out to see if it changes the function of that gene. So what happens in that mutation is the potassium channel does not open, and it does not allow the potassium to leave the cell, which results in pulmonary hypertension. So they are actually looking at a molecule which can make the channel open. Okay, and that they are doing by designing those abnormal channels in the lab and seeing if a medication works. So this is really promising. And if those tests turn out to be successful, it could potentially mean you give a medicine and the pulmonary hypertension, pulmonary pressures can come to normal. So this is the hope. And I think of all the potential drugs, KCNK3 appears to be the most promising in pulmonary hypertension.
Okay. Thank you, sir. The last question for this session is, how do you counsel your patients when mutation is found during pregnancy and post-pregnancy? And sir, your voice is a little bit breaking, and maybe if you can increase your volume a bit.
Is it better now?
Yes, sir.
Okay. So counseling with regards to, you mean like screening of siblings, or which aspect of counseling do you?
So for parents, means during pregnancy and post-pregnancy, how do you counsel the parents?
So a majority of these genetic pulmonary hypertension are autosomal dominant. Now, there are some autosomal recessive as well, but a majority are autosomal dominant. So if either of the parents carry that change, then there is a 25 to 50% chance that their next child will have it. And we can be very sure about it by doing prenatal testing. So this is usually done between 12 to 16 weeks of pregnancy, where you either do a chorionic villus sampling. You take a bit of tissue from the placenta, which connects the mother and the child, to see if there, or you do a procedure called amniocentesis, where you take fluid around the baby, and then you look for that specific genetic change. So the test which you do to look for that specific genetic change is actually close to 100% accurate. So if it says you have that genetic problem, you have it. If it says you don't have the genetic problem, you don't have it. So that is a good thing about that test. You can be 100% sure whether this child is going to be affected or not. Okay? And so I advise them to do that, and most parents do that. If it is negative, everybody is reassured and very happy. But then the question arises what happens if it is positive? Like, for example, I showed you this family with the hereditary hemorrhagic telangiectasia. So the father, the paternal grandmother, as well as the paternal aunt, all of them have telangiectasias, but they do not have pulmonary hypertension. Whereas both the children, they did not have, at least at the time we saw, did not have telangiectasias, but they had severe pulmonary hypertension, and one of them actually died. So even if the genetic testing is positive, the disease expression might be different in different family members. So this particular family, if they choose to have another child, that child might behave like the father and his siblings, in that he might have some skin lesions, which might look ugly or awkward, but who's able to live a completely normal life. Or he may behave like his siblings who had severe pulmonary hypertension. And that becomes very difficult to predict. So I give them the options, and I aid them in. I think the main thing is most parents have a decision made in their mind. What they need from us is support to make sure that their decision is the right one. So I'll again illustrate two examples which I've had in the last 2 years. This particular family with hereditary hemorrhagic telangiectasia, the mother became pregnant. She's actually pregnant now, and she's due for delivery in the first week of July. So she's almost 35 weeks pregnant right now. We did, my wife is a fetal medicine specialist, so we are sort of able to offer all of this in one roof. So we did amniocentesis, and it turned out that the baby inside the mother's womb also has this genetic variation for hereditary hemorrhagic telangiectasia. So when we had this discussion, both the parents asked me one question, like, is there a possibility like this child can be normal like the father, not have pulmonary hypertension. So I said, definitely there's a possibility, but there's also a possibility that he'll end up like the other two children with severe pulmonary hypertension. So their outlook was that if there's a chance that this child could be normal, we want to have the child. And they wanted me to support their decision. So whereas I've had one more family with BMPR2, where the mother became pregnant because she wanted a normal child. So she had this child who was suffering with severe pulmonary hypertension, and she wanted to have a normal child. She did not want to take a risk. Even though she carried the BMPR2 variant and she was asymptomatic, we did amniocentesis, and the child and the fetus had this BMPR2 variant. She was very sure that she did not want to go through what she had gone through with the previous child, and she chose to abort that child. So I think with genetic counseling, you just need to lay the fact, there's no right or wrong. I think what the first mother did was also right. What the second mother did was also right, even though their reactions were completely opposite. I think the key thing with genetic testing and counseling is, you need to support the parents in their decision. You need to put the facts to them. And as I said, I live in a Tier 3 city. All my patients, they're not very highly educated or from very affluent backgrounds, but they're still capable of making the decision for themselves. And I think the key is to just support them in making this decision.
Okay, thank you, sir. I would like to close this session now, and we will open for audience Q&A for Dr. Prashant, Dr. Neeraj, and Dr. Maniram. All three doctors, please be online again. And the questions will be asked by Shalaka now.
Yeah, I'm just pinning the doctors. Audience, parents in the audience especially, if you all have questions, please feel free to ask in the chat, or you can direct it to me. Some questions have already come in, and I would like to ask this question now. There's a question on sleep apnea in children and pulmonary hypertension caused due to it. Is there reversal of pulmonary hypertension when the sleep apnea is addressed, even in children? And how common is it to have this sleep apnea?
So it's
Dr. Bobhate, yes.
Yeah, it's not very common to have sleep apnea as a cause of pulmonary hypertension in pediatric population. Having said that, we have had 3 patients. It may not be actually always be sleep apnea. They sometimes can have neuromuscular disorders, which prevents them from breathing. So one of our child had that kind of problem. Other issues, if the child is very obese, especially somebody who is what we call as a Pickwicken syndrome, they can have sleep apnea. Down syndrome by themselves can have sleep apnea because of the tongue falling, because of the hypotonia of the upper airways. They can have sleep apnea. In fact, I had one child who had, he was very sick. He was oxygen levels were only 40-45. He had a heart disease. Like Dr. Neeraj had mentioned before, it was an AV canal defect. But he was just 2.5-3 years of age, and he was saturating only 40%, which is not expected. And then we evaluated him. He had a huge adenoids and tonsils, and we operated for him. His saturation, the symptoms changed dramatically. His saturation improved to 85-90% after doing that procedure. So yes, sleep apnea is one of a cause of pulmonary hypertension. It is more common in adults. In pediatrics, in certain subset of patients, we still see sleep apnea, and some of the pulmonary hypertension may be reversible if you treat it properly.
So just to add, Prashant has beautifully highlighted. We conducted one study where we evaluated all the patients of presenting to ENT clinic with upper airway obstructions to pulmonary artery hypertension. This was a thesis study of ENT department. So interestingly, we could not find even one patient of pulmonary artery hypertension. This was a prospective study. All the patients who were to undergo tonsillectomy, they went upper airway evaluation analysis, they went a sleep study, and they went an echocardiography for PH. But other way, if we have an associated risk, associated factors, say a Down syndrome, once you treat this, is definitely a factor which actually adds on to the underlying PH, but isolated itself in children to say that upper airway is a cause of pulmonary artery hypertension, I would still look for other causes in pulmonary artery hypertension.
Okay, thank you. Dr. Neeraj, that was insightful. There's a question for Dr. Maniram. Which type of pretest is more accurate in genetic studies?
Which type of?
Pretest.
Sorry, I didn't get that.
I did not understand the question myself, but I'm just going to quote the direct question. Which type of pretest is more accurate in a genetic study?
I think he means antenatal testing.
Okay.
Oh, okay. So I think preferably it should be amniocentesis. Because sometimes the reason is, yield of cells will be better in amniocentesis, which is taking fluid around the baby, rather than taking a bit of the placenta, which is called chorionic villus sampling. The advantage with chorionic villus sampling is you can do it much earlier. You can do it at even 11 or 12 weeks. Whereas in amniocentesis, you probably can do only around 15 weeks. But given a choice, amniocentesis is probably the better of the two.
Okay. Thank you, doctor. There's a question from a mother of a 12-year-old from Indonesia. Her child was born with TOS, with pulmonary atresia and severe pulmonary hypertension. She says the doctors do not suggest heart surgery due to the severe PH and have prescribed tadalafil and ambrisentan, which are not available in that country. Do you have any advice about medicines with this particular patient? Tadalafil and ambrisentan are not available in Indonesia.
So we are not really sure which are the medications available. So
Sildenafil is available.
So they can definitely take sildenafil, not a problem.
But that's it, like one monotherapy, and there is no possibility
no bosentan, ambrisentan, macitentan, nothing is available.
Katrina, if you can unmute yourself and speak if you can. Is bosentan available?
Hello.
Hi, Katrina.
Yes. Even bosentan is not so easy to get to for me.
Okay.
So actually, the prescription of tadalafil and ambrisentan is from a doctor from India too, because I brought my son to India last 2018.
Yeah, it's very difficult when certain medication is not available in a particular country. There are always ways to get this medications, like some of the medications which we give for our PH patients are not available in India. We have a way to import it. So you need to explore those pathways. Or otherwise, to begin with, you can just start him on sildenafil, and then you need to explore the pathways in your country. So we're not really sure what are the rules of Indonesia in respect to import of the medications, but you need to explore them.
Right. In fact, a few months ago, we had explored the possibility of one of the Indian pharma companies sending drugs, some of these important PH drugs to Indonesia, to their PH association. So I hope, we can explore this further. And even privately, we can send you medicines, Katrina, just, write to us. We'll try and figure out a way to support your son. Yes, Dr. Awasthy, you were saying something?
Thank you. Maybe
one second, Dr. Awasthy. 1 second, Doctor. Yeah, Katrina?
Yeah, maybe I'll contact you for the details regarding your previous experience.
Yes.
Is that okay?
Yes, please call us, email us. Yes.
Yeah.
All right. Thank you, Katrina. Yeah. Yeah, Dr. Awasthy, you were saying.
Yeah. So whenever you are discussing medicines, it is a good idea to have a detailed discussion about the underlying substrate of patients. We understand it was pulmonary atresia, and we understand that probably there was some collateralization, but I'm really not sure about the underlying problem which Katrina's baby is rightly having. So whenever discussing it out, do discuss it out with the physician, that is there really underlying substrate, what are the underlying substrate we are dealing because at times with the pulmonary atresia, MAPCAS, differential flows, we may not need all gamut of all the medicines. I mean,
Yeah.
of course, the best person to guide you is your local pediatric cardiologist or local person who deals with pulmonary artery hypertension, or need be any of us. But we need, all of us need a full clinical data set before we escalate a dose or initiate a dose of any pulmonary vasodilator. At times, like Dr. Prashant has said, just a sildenafil for iron migraization is also a very good idea. But
Okay.
that depends on underlying substrate of medicine and not just on single report.
Okay. Okay. Thank you, Dr. Awasthy. Yeah, that was important. I would
Thank
also
you
like to
very
mention. I would also like to mention here once that, especially to the parents of children with pulmonary hypertension, whether it's idiopathic, CHD, or familial, Pulmonary Hypertension India can help you source reasonable medicines from vendors around the country. So do reach out to us. We understand that some of the medicines are extremely expensive, especially the advancements, and we can help you source medicines at reasonable rates at deeper discounts. Just reach out to us and we'll help you with that. There was another question, and maybe Dr. Awasthy or Dr. Bobhate can take this. This is about when the heart defects or congenital heart defects not closed early on, or hoping that they would resolve themselves as the child ages, but that does not happen. And even otherwise, when the child develops some neurological or developmental challenges, is there something, are other doctors involved at this point in time besides a pediatric cardiologist? How do you all deal with this? Are neurologists involved? Do you all ask do you all counsel the patient, the parents to send the children to special schools? If either one of you all could speak on this.
So I think it's a very good pertinent question, which we might not touched it. Thank you for raising this particular point. We understand it's not just cardiology which is a problem of pulmonary artery hypertension. It is not just lungs which are a cause of pulmonary artery hypertension. We did touch the psychological and social aspects, the financial and the medical and those aspects. But definitely neurological is one of the important aspects of pulmonary artery hypertension. Why so? Because many of these congenital heart patients with a shunt or a hole in the heart are very predisposed to paradoxical embolisms. That means blood clots which form all over the body, which can go through these holes in the heart, can directly have an access to go to the brain. Unlike filters in us, where the lung is a filter, where they get filtered. Yes, many of them have. That is why need to have a periodic, regular follow-up. The prevention is the best form of cure. This statement, which we know since eternity, is very much true for pulmonary artery hypertension. Once you are diagnosed as pulmonary artery hypertension, be in touch with a good team which can evaluate you. It is not lung pressures. It is not just psychological, social once we are talking, it is this whole complete evaluation which is done. We look at any form of if the patient is ambulatory, if there's a point, if there is a chance that patient is not ambulatory and the blood can form clots in the lower limbs, or the patient has a tendency with frequent, once a year at least, a blood test to look for a tendency whether the patient is polycythemic or he has a secondary tendency to form clots. And once these clots form, there is a high chance that patient go into neurological deficits. Also, we understand that chronic hypoxia itself is a cause of some limitations of brain activity. So the level of, coming to the second part of the question, whether we need to involve some specialized clinics or specialized schools, it all depends upon functional status of the individual, the degree of deficits. Just to say that everybody would need a neurology referral, that or everybody will need a special schools, is no. Most of the pulmonary artery hypertension patients are very good at mentation. They can do an excellent job. We have a very good example. Shalaka is doing a wonderful job coordinating so many things. There are so many of us who are actually, it has nothing to do with any mental aspects. The pulmonary artery hypertension is a disease of lungs and the heart. And there is no, in most of the cases, there is no other systemic impact if the disease is appropriately followed up. Yes, the degree of functional limitation, as is true for the heart and the lungs, would decide whether one needs to take a specialized neurological opinion or a specialized opinion with any other specialized neurological associated problem if it is needed.
Okay, okay. Thank you, Dr. Awasthy. Dr. Bobhate, have you written any notes for children with PH for their teachers in school so that the school environment can support them? Have you had that?
Yes, yes, we
those
do.
requests?
Yes, we do that. Especially in children with pulmonary hypertension, we request the teacher to not involve them in competitive sports. That's number one. Second is if sometimes the school is, the class is on the second floor or the third floor, these children may not be able to climb those floors. So if the school has a lift, we ask the teachers to, request the teachers to allow them to use the lift. If that is not possible, one of the caregivers allow one of the caregivers to, either carry the child or carry the bag also. Sometimes the bags are quite heavy. So the child will be able to climb, but without the bag, but with the bag, it is a challenge. So we have done that, yes.
Okay. And do you also request the teachers to go easy on them academically or not really? You also mentioned that they're pretty intelligent because they're usually sedentary and reading. And we can relate to that.
Yes. Most of the PH patients are kind of, their mentation, as Dr. Neeraj has said, their mentation is usually not a problem. So they don't require help in or special help in the studies part of it, but the physical aspect they would require.
Okay, if I could just quickly offer my experience with this, because I grew up with CHD, I think the worst part was obviously climbing stairs in schools and colleges, but another thing was about writing exams. I couldn't cope with writing, continuously. It would tire me out. Probably, oxygen not reaching enough to my extremities or something like that. But that would become a huge problem for me, and that would, worsen my handwriting, and that became an academic issue in itself. That she wasn't able to cope with writing so much. Yeah, Dr. Awasthy had something to say.
Yeah, Shilaka, then you should have become a doctor.
Yeah, that's a missed opportunity.
Because if you say handwriting as one of the aspects, I think you can always compare with us.
Yes.
So, this statement has got an undertone, which I want to with the limitation. Pulmonary artery hypertension is not a limitation. Pulmonary artery hypertension is a disease, if appropriately coped with appropriately social support, can easily be taken. And one can actually, interestingly, I know this may sound a slight different. Interestingly, just before we had to have a meeting, there was one patient with pulmonary artery hypertension sitting in front of me who said that he wanted a note from me that the school should allow him to, because once they have mentioned that he's having pulmonary artery hypertension and he cannot, they are not allowing to do anything at all. He is just allowed not even to do exercises. Yoga in the school is also limited for him. I mean, at times the school take a burnt excessively.
Yeah.
I mean, this may be a different aspect of the whole thing, but this is something which I faced around. It's a form of discrimination. So not that the teachers need to be primed, that not they. We want some support from them. I remember I told you it's a supportive care, not a palliative care. We want some support from you, but not the palliation. Not that they are very much part of the school. They have to be very much be part of the activities. If the child cannot run, if he is not allowed into competitive sports, he can be given a whistle to blow to stop those running students.
Yeah.
So this is what I want to say. He can be a whistleblower for those who are running, and whistling is very good for him. He's exercising his chest. So these are some things. He has to be part of all the community activities which they are doing. Not that you sit in the class and rest of the people are playing. No, if rest of the people are playing, they need a scorer to score the runs. They need somebody to look at them, to take care of the person who are running around. They might fall down. They might need somebody. The teacher may need somebody to get assisted. This we have done in schools. We have taught to the school student that we don't want our patients to be to be special students. We want them to be excellent students.
True. So it requires a lot of maturity from the academic community as well.
From the academic community, from the teachers, that you come forward and don't just discriminate them. Just let them be part of it. The parent was very apprehensive. He said, my child is not told. Once I've told them, they do not allow him to do anything. I want a change of school, but the change of school also wants a letter from you.
True.
So this is something which may sound something different, but this is a different aspect actually.
Okay.
Yeah,
Thank you, Dr. Yeah, Dr.
Interesting anecdote, similar to what Dr. Neeraj had mentioned. So, there are some teachers who are more hands-on, who don't actually discriminate that much. So I have a family with long QT. The channelopathies are my main interest. So I have a family with long QT where both the siblings are long QT1. And I usually teach CPR for the parents. And, they both study in a government school in a village close by. So one of the teachers from the school actually volunteered to learn CPR because he said, what is that happens in the school? We won't be able to help them. So I think, there are some schools and specifically some individuals in the schools who are more accommodating to the demands of specific students. But as Dr. Neeraj mentioned, the vast majority are not like that.
Yeah. And I mean, hats off to a government school teacher to want to learn CPR to, support her student. That's amazing. That's amazing. There was also a question on congenital heart disease and PH, and maybe Dr. Prashant Bobhate can take this. Doctor, the question was, if they run out of options, and we know that lung transplants are also, it's a difficult option and not an easy one to access. But would these patients require both heart and lung, or only lung transplants?
So in patients with congenital heart disease and pulmonary hypertension, the transplant is the last option. And, more often than not, they do well without the transplant than with the transplant. Okay, so patient with Eisenmenger syndrome, the median lifespan is 50 years. That means 50% of the patients will live more than 50 years. Okay, so which is as good as a normal individual, maybe 10-15% less. If you don't close the hole, that is, we're talking if you don't close the hole. So if you don't close the hole, the median lifespan is near normal. They may have some exercise limitations. They may get a little bit desaturated. They may not be able to, run a marathon or do such kind of activities. But transplant definitely is not an option for them till their end stage. And in that scenario, more often than not, it is a heart and lung transplant. And as we all know, a heart and lung transplant has a much worse prognosis as compared to only lung transplant. So lung transplant by itself, if you compare all the other transplants, lung transplant, the results are not great. Heart and lung transplant, the results are even less optimal. And so these patients would do well to live with their heart disease and with pulmonary hypertension into the adulthood rather than go for transplant.
Okay. Understood. I don't see any other questions here. So I think, Prashita, we should close.
Yes, we have already exceeded the time limit. So actually, about the caregiver perspective, we are very sorry that we couldn't bring a caregiver perspective today, as our caregiver had to drop out due to some emergency. So very sorry for that. And before closing today's event, I would like to thank Dr. Neeraj, Dr. Prashant, and Dr. Maniram for patiently answering our queries. And there are so many takeaway messages today, but I would like to highlight a few. Firstly, that the PH is a family disease and a good family counseling is a must. Then secondly, if the CHD is closed or open, means unoperated or operated, but the child is showing symptoms, example fatigue, please go to the doctor, and follow-ups are advised by doctors based on patient status. And lastly, genetic testings are important, not only for diagnosis, but also prognosis and future genetic therapies. Once again, thanking the doctors on behalf of PHI, as they are helping us in spreading awareness of PH across India. So thank you very much, doctors. And I would like to thank the social media team of PHI and all the viewers who attended this very informative and eye-opening session. Thank you and have a good evening.
Thank you.
Thank you, doctors.
Thank you. Thank you.
Thank you so much.